Good morning, everyone, and welcome to Day 2 of The Way Home, a virtual summit on homelessness, serious mental illness, and substance use disorders. This session is our opening plenary for the second day, From Outreach to Housed with Care. My name is Kristen King, and I'll be your producer for this session, as well as several others throughout the day, and I have a few quick housekeeping items to go over with you. I do want to let you know this event and all other sessions in the summit are being recorded. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services or the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. I'm going to open up the line for our moderator, Marty Fleetwood. You met Marty yesterday, and Marty, I'm going to turn it over to you now.
Greetings, everyone. Hope your faces are smiling this lovely morning. This is day 2 of our Gathering of the Field. We're really pulling together people that work on homelessness, whether they are treatment providers, clinicians, some of you may be researchers, some of you are practitioners, case managers, some of you provide housing, some of you are social workers. There are people here from all over the country, from sea to shining sea, and who play a plethora of roles within this world that we work in. So we're really glad to have you all coming together in this way. The chat box has been very helpful to get a sense of what people do and where you're from and what your experiences are in relationship to the material that we're talking through. Yesterday, day 1, we really flew through a number of ideas and data points and program examples and questions about our treatment and service capacity in working with homeless people. So today, our day 2 of the summit, we're going to be looking at similar issues, diving a little deeper into some of the subtopics, and considering a number of the really bold points that were made yesterday about things like the power of collaboration, working with health centers and housing providers to meet needs, the importance of cultural competency to reach equity in our outcomes, the need to collect accurate data and analyze it to inform and reform our work. That's just the beginning of a very long list of the things that we're deeply focused on yesterday. So as with yesterday, our sessions today are in 3 tracks: facilitating access to prevention, treatment, and homeless services, intervening early, and improving services for those who have serious mental illness and or substance use disorders. The sessions that we had yesterday, like today, plenary session, and then in each of those tracks, facilitating access, intervening early, and improving services, there were 2 workshops, just as there will be today. At the end of the tracks and the information, we'll have a closing plenary where we'll look to pull together what did we see, what did we learn, what did we hear, what are the questions. But the big question, the overarching thing that we're looking to do is connect the dots so that we have a sense of where our field is going. What are the practices we should all be engaged in? What is the data we should all be collecting, and how should we be analyzing it? What is it we're looking for in that data? What are we aiming to do? How are we improving our outcomes, and how can we improve what people receive from participating in our system? We're really considering what is our way forward. To start us off this morning, I have the great pleasure to introduce Dr. Louis Trevesian, who's the director of the Center for Substance Abuse Treatment with SAMHSA. Dr. Trevesian is an actual doctor, an addiction psychiatrist, focused on substance use, mental disorders treatments, but a special focus on the older adult population, which we learned yesterday is a growing percent of the homeless population. His bio, as all the bios, are in the plenary packet that you received yesterday. There's a sort of overarching electronic program for this entire summit, and you can click on plenary sessions, you can click on bios, you can click on presenters, you can click on the sessions you want to go to. There's in the presenter packet and the bios, you'll be able to read the full bios of each person. So I just wanted to remind you of that, and then I'm going to go back to describing some of the things Dr. Trevesian has done. He's worked in Connecticut with their Veteran Affairs healthcare system. He's been at Yale Medical School, working with students and psychiatry residents and chairing the performance improvement efforts. He's worked with veterans, the Integrated Service Network. He's been a direct provider of substance use disorder services using telemental health to rural areas. Questions came up about this yesterday, so I wanted to highlight that he's worked in that area. Dr. Trevesian, I know you have a lot to say to us this morning, so I'm going to turn it over to you.
Thank you very much, Marty, for that wonderful introduction. It's a great pleasure to be with all of you today, and I'd like to welcome you to Day 2 of our virtual summit on homelessness, serious mental illness, and substance use disorders. I am new to SAMHSA and the Center for Substance Abuse Treatment, but I am not new to the intersection of homelessness, serious mental illness, and substance use disorders. I am pleased to see that SAMHSA has a long history of understanding how important it is to address these issues in an integrated way. In fact, the homelessness programs at CSAC and the Center for Mental Health Services have worked together closely for years, supporting the work that you do. We strive to connect people to effective treatment. We want to also promote recovery from mental and substance use disorders in the broadest sense, helping people restore health, establish homes, join communities, and find purpose. I'm going to echo my colleagues thanking you for everything you do. We are all busy, but it is important to take time to do what we are doing today, learning the latest about what works, sharing with our peers, and thinking creatively about how to overcome the challenges we may face. And I look forward to getting to know some of you and learning about your work. So again, I begin a big welcome from Assistant Secretary of Mental Health and Substance Use, Dr. Eleanor McCants-Katz, and all of us from SAMHSA. Thank you very much. I'm back to you, Marty.
Thank you. Appreciate you being with us this morning. Our first presenter for this panel is going to be Brian Sims, but before Brian is introduced, I wanted to show you the kickoff moment that we are in now. So this is our launching of Day 2, and we're asking a number of questions that we also asked in Day 1. What do we see in the field and in national findings around serious mental illness and substance use disorder services and treatment? How can we design and implement programs that address the social determinants of health? And how can we safely and effectively address serious mental illness and substance use disorder needs and provide services to homeless outreach efforts? So our presenters are going to help us with that task in this plenary session, Outreach to House with Care. So Dr. Sims, I'm introducing using, again, the bio that's available in your packet that everybody has available electronically, is a subject matter expert focusing on trauma-informed care. He works with the National Association of State Mental Health Program Directors, where he is their senior medical advisor. His work on trauma-informed care is looking at developing strategies for systems to become trauma responsive. So this is one of the important pieces of yesterday's work that we did, was looking not just at our programs and practices that each person would do in their own agency, but looking at how to collaborate across agencies and paying attention to the intersection of work between numbers of agencies in a community. That's a system, looking at how to work at a system. So Dr. Sims figures out how to deal with the trauma-informed responses that systems need to be cognizant of. He works on developing key strategies for change to improve patient outcomes. Another point that was touched upon yesterday is how do we make sure that people are achieving the point that we need them to achieve. So Dr. Sims, we're really glad that you're here with us, as we were glad to have you with us yesterday, and look forward to you taking it away now. What do we see in the field?
All right. Well, first of all, good morning to everyone, and thank you, Marty, for that gracious introduction. Let me just share first and foremost how honored I am to actually be a part of this discussion, not from the realm of giving you a lot of hardcore data, but just to say to everyone the marvelous outcomes that we're seeing across the country So I'm excited to be able to provide some of this information. And just looking at the large participant list, this really tells me that the investment into hope and help for the people that we serve is tremendous. And what will follow is a generalized overview, and it's really intended to highlight what is seen locally and nationally, and what many communities have indicated to be their major challenges. Now, while most of us are aware of the high prevalence of serious mental illness, co-occurring disorders, persons experiencing homelessness, as well as criminal justice and veterans issues, what I intend to do is focus more on what data has been presented, and in the end offer a couple of positive examples among the many that we've seen in the field across national as well as international boundaries, showing how systems can coordinate and collaborate their efforts, and in it actually see and find solutions. So I'm going to go to the first slide, and this first slide really just kind of overall maybe a bit boring in one respect because you've seen it so many times, but I think it's important to note what serious mental illness is all about, because sometimes we get oversimplified in our definition and we see individuals as their diagnosis rather than as a person. But we know that under serious mental illness it can include major depression, schizophrenia processes, bipolar disorder, OCD or obsessive compulsive disorders, panic disorders, and post-traumatic stress. That alone tells us of the large number of individuals that are suffering with these particular disorders at the present time. Now, I give you that slide only to move to the next one, because what I want to show in this slide is how complex this issue is. We've always, and I remember a number of years ago when I had a patient of mine that said to me, very clear cut, Dr. Sims, you need to understand I am not my diagnosis. And I think this is a wonderful slide to show the challenges that all of the communities tend to see, is that it's not just about a diagnosis. There is a complex intertwine of serious mental illness with a lot of issues that all of us encounter every day. And you can only imagine that if a person is suffering from any of the serious mental illness disorders that we've outlined already, and then add to that these other factors, how complex it can not only be for the individual, but for the community services that are attempting to treat them. You look at things like the income, where the person lives in the community, how they relate to other individuals. You look at things that we don't tend to focus a lot on, but the person's ability to sustain a proper nutrition, physical activity, all need to be looked at collectively, because as you'll see, these all have a contributing element to the healing of that individual and to the potential barriers that most communities see when they try to address these individuals. Now let's move to taking a look at a huge issue that we see in all communities, and that is one of homelessness. When we look at homelessness, it's interesting that a lot of times when we tease the figures, many of the figures that we see across the country tend to take a look at splitting out some things. And this particular slide is just a small portion. It's taken from a small community in Alabama. I took a look at around 1,000 homeless individuals and divided them into their reasons and their factors that were contributing to homelessness. And what you'll see from this is a lot of similarity for what's going on in communities all around us. I want you to focus on the last three at the bottom. You notice that they comprise a huge percentage. When you take a look at, and you can even add prison to jail, but when you combine those two, you're looking at roughly 18% within that community of individuals who are homeless have histories of being incarcerated, but also 14% substance abuse. And then the largest piece, which sometimes surprises people, is loss of income. It's about the most clear-cut reason that people tend to present for homelessness issues. Now, take all of these factors and combine them with suffering with any kind of serious mental illness, and you begin to really appreciate the challenge both on the part of what people see and what the communities then have to contend with regards to helping this individual move to a more productive level. Now, this impact is seen very clearly when you take a person who has any type of serious mental illness and a concomitant substance abuse issue. You see that roughly 30% of these folks suffer from an untreated SMI, and that approximately 26% experience homelessness in dealing with these issues of substance use. What am I really doing is just kind of making sure that we open up the doors to the understanding of the importance of co-occurring disorders. Now, I'm an older psychiatrist, and I've been practicing for a number of years, but I remember way back when there was this functional disconnect within the communities regarding substance use and mental illness. The two never communicated very well. People were treated in vacuum settings, but the importance and what we're seeing in the field nowadays is that the communities are beginning to embrace the understanding that co-occurring aspects is the most prevalent and most functional way to be able to help individuals. Now, this untreated mental illness, as you can well imagine, can impact these individuals' ability to do all those things we referred to in the prior slide, affecting their ability to sustain employment, to be able to be productive individuals out there in the community. But they also, and this is also a piece that we sometimes overlook, is that even if we help individuals and we find them places to stay, that alone is not sufficient in helping them to be able to continue their treatment processes. So a lot of this is community outreach to not only provide a system of care, but also help individuals to be able to sustain and continue treatment so that they can further improve. Now, take a look at this particular slide from the Journal of American Medical Association. They document that roughly over a third of individuals who misuse alcohol and 53% who misuse drugs have at least one serious mental illness. So what are we doing? We're really kind of forcing the issue for the understanding that co-occurring disorders is the current methodology of thinking in terms of successful treatment. You have to treat the whole individual. And this is data that just is so compelling that I'm hoping that it will be embraced, because we're certainly seeing this across the nation, that community resources that are focusing on co-occurring treatment are seeing a great deal of improvement coming in. Now, let's take a look at what is happening in the field, because it's somewhat disconcerting to a certain degree, but a reality check for a lot of us. If you take a look at the SAMHSA data here, 2.6 million adults that have a co-occurring disorder, the focus here is what happens to them. What tends to happen within our communities, and what we see is still that we have a great deal of work yet to do. Because if you notice, there is still, to a certain degree, of unfortunate nature, for lack of a better word, that many of them are still teased out in their system. But look at the fact that roughly a third of them are receiving no treatment whatsoever. And then when you begin to look at the other data, you see that many are still receiving pocketed treatment in terms of mental health treatment only versus a substance use treatment only. So we still have a way to go, and want to make sure that people understand that that co-occurring aspect requires that the whole individual and what's going on in that person's life needs to be the focus of the community resources that are made available for them. Now, let's take a look at another population that tends to be overlooked, and that is our criminal justice system. Because many of you are aware that within your communities, I don't have to give you the specific data because that takes a long time, but what we do understand is that a large percentage of individuals who are in need of mental health treatment find themselves in jail for a myriad of reasons, and those reasons can be simple items, misdemeanors that will land them in jail, but they get there while they are still unstable. And when you take a look at the data here in the prisons, 2 to 4 times higher than in the community. So when the community starts to take a look at how do we make a difference, then we also need to include what services are there. And in the community and across the nation, the data that we're beginning to see is that more communities are beginning to embrace the mental health court systems, and the assessments of individuals prior to coming into the jail systems to see if there are alternate services so that they can be provided with that prior to coming into jail. So there's some very good data that's beginning to show that people are more responsive now in taking care of this particular problem. Now, let's also take a look at a huge population that tends to get overlooked a lot, and that is our veteran population. In this veteran population, if you notice from this particular slide, there are a couple of things that are very important that you want to take a look at on this slide. First and foremost, you're dealing with the most recent conflicts, the Vietnam, Iraq, Afghanistan, and other recent conflicts. But what I want you to do just on this little teased out piece of data is that roughly half of the homeless individuals amongst veterans are from the Vietnam era. And the Vietnam era, we don't need reminders, was an era that ended in the 70s. So we still have a tremendous amount of work that is still going on to find the right pathways to assist individuals who are veterans, roughly 30% of them from Afghanistan and Iraq. So the path is often complicated by the fact that these individuals not only are homeless, but are also suffering from serious mental illnesses and substance use disorders. Now, like I had mentioned a little bit earlier, even if they are found to have housing and they are able to obtain it, the veterans themselves feel further isolated, and they end up coming into emergency rooms more often, going into hospitalizations. So there's still more that needs to be done in terms of raising awareness of the specific treatment needs. And we talked a little bit about this yesterday, but one of the ways was certainly looking at peer support as one of the strong issues to be able to connect people not just to understanding what is going on, but also being able to support how much hope and how much positive nature can be obtained if a person begins to seek those services. Now, what I want to do is close out with just a couple of examples of services that I've had the honor of being a part of in terms of my knowledge of them. And the first is this particular team called the HOT team, or Homeless Outreach Team, and they're based in Baltimore, Maryland. And what you see in the picture are 3 Baltimore City police officers who take it upon themselves at the close of their day to put on T-shirts that have Homeless Outreach Team. They get their own vehicle, and they drive through all of the neighborhoods, and they seek out the homeless individuals, providing blankets, providing services. They take them to doctors. They take them to substance abuse centers and so forth. And the amazing part of this particular data is that they've been able to actually show that they are building collaborative relationships, not just with the homeless individuals that they are interacting with, but also with substance use services, the emergency room settings, and the partners and agencies that are already operating within the city of Baltimore. And what are they doing? They're attempting to provide that huge issue called hope. And in this case, their hope is happy, optimistic, powerful, and empowered. They are empowering individuals to be helpful. I just show you this slide just to give you some data, because I think this is something everyone is aware of, that it is far better to service an individual to help them to be able to get through some productive steps than it is to keep them homeless. And you can see from the savings how that would be a dramatic improvement. Now let's go lastly into a model that is used, and I have to take my hat off to the folks in West Virginia. This is a phenomenal program that was started a number of years ago based on the fact that many children who have been experiencing trauma in the community from various things, from homelessness to abuse to other types of things, what they have noticed is that many of these kids tended to misbehave, and the school system's not having any other opportunity to work with them, would end up expelling them. These kids would go to the streets. What this program did, in short, was it was a collaboration between the West Virginia State Police and the school system. And if a school-aged child had an issue in the community that the West Virginia Police would investigate, the first thing that they would do is take a report, they would get the child's name, and they would call the child's principal of the school that the child attended. And they would say 2 things to them. They would say the child's name, and they would say the words, "handle with care." that principal would then contact the teacher of that child and say the same two things: child's name, handle with care. When that child would come in the next day, maybe misbehaving, not dressed properly, hasn't had breakfast or otherwise, and is disruptive, the teacher now knows that something happened to that child, and they practice comfort rather than control. I'm giving you this example not just because it's about schools, but it's about church systems, it's about community-based components, but it's an effort that is really embracing across the country to show how things are really improving. So on that note, thank you very much for your time, and I'm going to turn it over at this point back to Marty. Thank you.
Thank you. Excellent. Wow. We have so many questions coming at us from things that you've said, sparking thoughts in people. We're going to hold your questions, though, and hear from all the panelists so that we can have a full picture of the spectrum of information available today from this sort of national data perspective and experience Dr. Sims has had to what does a state do? How does a state system of care respond and organize itself to work with these issues? To how does a person who's on the street working with clients deal with these issues? So our panel is very well comprised to dive deep into issues. We're going to do that, and then we'll come back and interact around all the questions. So I have the very great pleasure to introduce Melody Pasalt, with whom I've worked in her home state in my ramblings around the country trying to get state systems to integrate the knowledge that has emerged on homelessness and how to respond. Melody is one of the leaders that I had the privilege of working with. She really has stayed in her position within Washington State in a way that led to system reform. It's as if she is a human integrator. She makes system reform happen by paying attention to what is taking place around the country, what is the research saying, what are the trends, and how can her system adapt and apply those various modalities of ways of handling things, collecting data, figuring out what needs to be done, and just getting it done. Does that mean change policies and procedures? Fine, she does it. Does that mean get some budget changes through the legislature? Fine, she knows how to make that happen. Does that mean reaching out and collaborating with 8 other departments and 16 entities around the state and various counties? Fine, boom, Melody does it. So I really hope you all will listen to Melody, because from her role as a manager in the Behavioral Health Program and Recovery Support System, she keeps the work on track. She identifies who needs to be housed, builds effective delivery systems for providing housing and treatment in a community, and integrates employment. All right, Melody, take it away.
I hope the presentation lives up to that great opening, and thanks so much to the previous presenters and for SAMHSA for hosting this. This is a great opportunity to share what Washington State is doing to try and address the social determinants of health and really looking at the impact that homelessness and long-term unemployment has on people's health. So I work for the Healthcare Authority in Washington State. That's a new move for us. We were at the Department of Social and Health Services within the Division of Behavioral Health and Recovery, and 1 year ago, July 1st, we moved and integrated with the healthcare system. Washington is really starting to pay attention to integrated health, and we have the last of our 3 regions that will be moving towards integrated managed care purchasing with that effort of really looking at whole person health. And it's one thing to integrate your mental health and substance use treatment service delivery system into healthcare, but it's another thing to really start paying attention to the social determinants of health. And data really helps drive those decisions. So we have a fantastic data system in Washington State. We have a division that's dedicated to looking at multiple data systems, and that division is called the Research and Data Analysis Division. Years ago, SAMHSA sponsored a mental health transformation grant that helped us move that integrated client data system for research and data analysis to be able to look at multiple data systems, and they can really cross different administrative data sets together and looking at people coming out of inpatient behavioral health settings, looking at state hospital usage, and looking at homelessness. And so they issued these reports in 2010, really taking a look at, for those folks that are coming out of substance use treatment programs, how many were actually had a housing need. And so what was really astounding is that almost 50% of people exiting substance use treatment programs were homeless within the year of exit. So that was really astounding to be able to see such a stark number. Another really significant data point that we saw was almost 30% of folks coming out of our state hospital were homeless within a year. And so it really caused us to take pause to look at how are we actually really helping people bridge out of these really high cost intensive settings to really try and address their housing or homeless instability. We also, the Robert Wood Johnson Foundation recently put out some information that's really, again, also very telling around the impact that long-term unemployment has on people's health. And so, again, really starting to take a look at these social determinants of health and how they impact people in behavioral health and just how that impacts whole person care. So people that are unemployed are 54% more likely to have fair or poor health. Individuals that are unemployed are more likely to have stress-related conditions such as heart disease. And we know that unemployment has also been linked to loss of health insurance, increased stress and blood pressure, unhealthy coping behaviors, and increased substance use, as well as increased depression. And so as a healthcare system, as an integrated whole person care health system, we have to look at homelessness and long-term unemployment and how it impacts health. So how Washington State is addressing that? Well, we've actually had some really significant legislative direction. So in 2013, we had two pieces of legislation that really helped us drive and address these issues. One piece of legislation really required us to measure our outcomes of our system. How are we doing around getting people housing? How are we doing around improving the employment rate for people with behavioral health conditions? In a point-in-time report that we had around our employment rate, people in outpatient mental health treatment services, our employment rate was only 10%. So we had a 90% unemployment rate for people in a given quarter that were unemployed. And so really taking a hard look at what are we doing as a system to send the message that employment is healthy, it's important, and also then housing, and what are we doing as a system to really address homelessness. And this piece of legislation also required us to implement evidence-based, research-based, and promising practices. And so the Washington State Institute for Public Policy actually created an inventory of those evidence-based, research-based, and promising practices. And both the IPS, Individual Placement Support Model, and the Permanent Supportive Housing Model are on that inventory. We've also been very fortunate to receive a lot of support from SAMHSA. We had two policy academies. We were chosen as a state for Chronic Homeless Policy Academy, and that led to Marty coming in and really helping us develop a strategic plan on how can we impact chronic homelessness in our state. Our goal was to house 3,000 individuals that were chronically homeless, and so that strategic plan really gave us the North Star to continue to address these issues and looking at service delivery, looking at opportunities under the Affordable Care Act, looking at data, partnerships, working together to address these issues. Another policy academy from SAMHSA was the Olmsted Policy Academy that allowed us to really pay attention to the employment rate for people. We also, in another piece of legislation, received the statutory authority to be able to deliver supportive housing and supported employment services in Washington. And so that piece of legislation also started us down the pathway of integrated care. And then we were also fortunate to receive a CMMI grant in Washington State to really start looking at the whole person care model. So all of these building blocks really helped us move towards a number of projects, including our continued efforts around homeless outreach. So we are one of the states that has PATH. All states have the PATH, the Projects for Assistance in Transition from Homelessness. We've really focused our PATH program to focus on those folks that are literally homeless, that are unsheltered. And you can see from the two graphs, the yellow circle pie chart for Washington State, it really represents our really strong efforts to focus our homeless outreach to those folks that are literally homeless, that are unsheltered. And so our PATH programs really help feed the services that I'm going to be talking about through our 1115 Medicaid transformation demonstration to be able to provide supportive housing as a Medicaid reimbursable service. We've also utilized the State Targeted Response Grant, the State Opiate Response Grant from SAMHSA to expand our homeless outreach and to add peers, people with lived experience, to do homeless outreach to those individuals suspected of opiate use disorders. So now we've, on the PATH program, are using peers largely in our PATH teams to do homeless outreach for people with suspected mental health issues. And then our STAR Peer Pathfinder program is using individuals with lived substance use disorders to be able to do homeless outreach to individuals that are that have suspected opiate use disorders, so that we can really try and expand our homeless outreach to get those individuals access to treatment and into supportive housing services. We also use peers through a program called Housing and Recovery Through Peer Services. So this project was a direct correlation to that data that I first showed. Folks coming out of inpatient behavioral health settings need that bridge to help people, to help out into housing. And so our HARPS programs utilize peers to provide supportive housing services by developing that housing plan while that person may be in that inpatient behavioral health setting, and then bridge people out into the community and provide those supportive housing services. We also received bridge subsidy funds from the legislature, state dollars, to be able to pay for first and last month's rent, deposits. And so part of what we have done with the HARPS program is to really go into those inpatient behavioral health settings and develop those relationships and be able to get people connected to housing directly from those inpatient settings. Washington State also is, we have a very large investment in Oxford houses with a revolving account to be able to help start new Oxford houses. We actually have over 300 Oxford houses in Washington State and also fund some support staff to support those houses. And again, I already mentioned the Chronic Homeless Policy Academy. We've also been doing a number of projects related to employment. So we have a SAMHSA grant called Becoming Employed Starts Today. This has allowed us to do a social media campaign to educate employers on the benefits of hiring people with behavioral health conditions. Both our employment efforts and our housing efforts incorporate peers in everything we do. So our Becoming Employed Starts Today also incorporates peers, as do our supportive housing efforts. In fact, we actually created a continuing education curriculum for peers on supported employment and also one on supportive housing. We did that in partnership with Advocates for Human Potential with SAMHSA's support. We also utilize and have built out a number of resources like our Pathways to Employment, which really educates people on the myths associated with going back to work and the impact on governmental benefits. And so the Pathways to Employment actually has a benefits estimator as well as a number of other tools. We're also just completed a pilot on using the IPS model for individuals on TANF that also have behavioral health conditions, and 50% of those folks in that pilot were homeless. And so that pilot and that report is available on the Research and Data Analysis website. So all of these different efforts led to the pursuit of an 1115 Medicaid transformation demonstration waiver to be able to provide supportive housing and supported employment services as a Medicaid reimbursable benefit. So these services basically entail support, doing an assessment. What does that person need in housing? Really following the IPS model and the permanent supportive housing fidelity to the models, and making sure that people's choice in housing, affordability, clean and safe housing. We are, of course, experiencing a housing crisis in Washington, just like many other states, so the housing stock is very challenging. But what we find is that the homeless service delivery system has been delivering these services, and how can we now, as a behavioral health system, as a healthcare system, be able to provide those services so that the funding in the homeless safety net can be really actually used for housing, to be used as subsidies to pay for housing, to partner with our Housing Trust Fund to develop those three legs of the stool on the services to support somebody to obtain and maintain housing, to build more affordable housing, and to pay for those subsidies for private market landlords in the community. So we applied for the 1115 demonstration waiver in August of 2015. We received our special terms and conditions from CMS in January of 2017. It took another 11 months for us to finalize the protocol with how we were going to deliver these supportive housing and supported employment services from Medicaid. And so those services, and very clearly what those services are and what those services are not. So they are services to support somebody to obtain and maintain housing and obtain and maintain employment. We cannot use Medicaid funds to pay for rent or to subsidize somebody's job. So it is clearly just services. But as I mentioned, this then frees up the homeless safety net for them to actually use their funds to pay for those rents, to pay for that housing. So we launched Foundational Community Supports, aka Supportive Housing and Supported Employment, January of 2018. We work through a third-party administrator that is a managed care organization in Washington State to manage this enhancement to our service delivery system. They in turn then contract with a variety of providers, some housing providers, some community behavioral health agencies, some community nonprofits, so a variety of agencies that deliver these services. So who's eligible for these Medicaid benefits? Well, of course, individuals have to be on Medicaid. They have to be at least 18 years old for the supportive housing benefit, but they can be actually 16 and up for the supported employment benefit. This is really an enhancement to our service delivery system. So the medical necessity is established through either having a long-term health need or a serious mental illness or a substance use disorder or a long-term care need that affects that person's functioning and adult daily living skills. So the medical necessity is established through our already existing systems. Then from that, we have target populations for these Medicaid benefits. So for the supportive housing, the target populations are individuals that are chronically homeless or individuals with frequent or lengthy stays in institutional settings, such as prison, jails, state hospitals, or individuals with frequent stays in residential care settings, or frequent turnover of in-home caregivers, or individuals that have a PRISM risk score. And so our research and data analysis division created an algorithm to be able to identify individuals that were on Medicaid that may have a propensity of costing more than the average person on Medicaid. So a PRISM risk score means that they are, of 1.5 means they're 50% more expensive to the average person on Medicaid. For supported employment, our target populations are our state general assistance program called Housing and Essential Needs, or age, blind, and disabled. So these folks are on that pathway towards disability benefits. And if we can wrap supported employment services or intervene with supported employment services, maybe we can divert somebody from a life of poverty on disability benefits. Or individuals that have difficulty obtaining and maintaining employment due to their age or physical or mental impairment or traumatic brain injury. Or individuals with substance use disorders with multiple inpatient treatments, or individuals with serious mental illness or co-occurring mental health and substance use disorders. So we really try to be inclusive of whole person care and not providing these services to any one system, but really thinking about individuals may have multiple systems in their life, and so really trying to create a no wrong door for those systems. So how are we doing in the 18 months that we launched the benefits? Amazingly well. So we have just came out the door, and just the system is people want to work, people want housing. So right now we're on track for our to reach our enrollment our enrollment goals of having over 5,000 people enrolled. And so it's been amazing, the interest. So we currently have actually just about over 5,000 people enrolled. The last report that I ran, we have over 108 agencies under contract. Those agencies represent over 300 sites across the state that are delivering supportive housing or supported employment services, or both. We have about 600 or 700 individuals that actually are enrolled in both. The data in this report that is from January. I do have more updated information, but at the time we had to submit our slides. This was the data that I had. So this just runs through some of the demographics of the individuals enrolled in the benefits. One of the things as a healthcare system we're looking at is the type of Medicaid that people have. And Washington State is an expansion state, and so almost 50% of people enrolled in the supported employment benefits are in the expanded population. 33% are in the categorically needy, blind, disabled, such as SSI, SSDI. We also are seeing more folks on TANF that may have one of those complex issues, as well as our youth program. For the supportive housing, almost 44% in the expanded population and 40% in the SSI population. One of the things that was really interesting to look at from my perspective was how many folks are homeless that are interested in supported employment. And so 24% of folks on our Housing and Essential Needs, our state's general assistance program, that they have a housing need, and so are enrolled in our supported employment services. And 10% of individuals that are chronically homeless are enrolled in supported employment. What was really, really exciting, particularly with the work on the Chronic Homeless Policy Academy, was are we reaching those folks with these new benefits that are chronically homeless. And so 26% of those enrolled in our supportive housing services are chronically homeless. So we know that we're reaching those really significant populations with these new benefits. This fall we'll be really able to share the outcomes of this program. We know that people, from the success stories that we're receiving, that people are getting housed, they're getting jobs, and we hope to be able to report soon on the impact of these new Medicaid benefits. So that's a lot of information, and Marty, I will turn it back over to you.
Thank you, Melody. Didn't I say she was amazing? really great work has been happening in Washington State, something we can all learn from as they take what's allowed under Medicaid and create state-run programs. So while the language and some of the features of their program are what was designed for Washington, it's the Medicaid system that is set up to allow these things to happen. So congratulations. We'll get back to the other dozens of questions that came in while you were speaking after we hear from Amanda. Amanda is the amazing street nurse of Sacramento. Feels like she ought to have her own TV show. She provided on-demand care for over 200 people and developed trust with this medically fragile population. Sacramento has an unsheltered street population that has been high for a very long time. And being able to be the person who goes amongst the folks on the street allowed her to really provide education and advise people and deliver care right there in a street setting. This is not an easy thing to do. It's something that some communities shy away from. And Amanda, we're really looking forward to hearing how you did it, what you did, and what you have to share with everybody else. So could you please tell us?
Thank you so much. Good morning, everybody. So currently I'm working in a different position, but I did outreach and a lot of engagement and on-demand street nursing for about 2.5 years in Sacramento. And that included being on the street and in a lot of camps. We have a lot of people living on the river here in Sacramento. And I did a lot of different things. I did some basic, very much nursing-focused things, and a lot of it actually included just a lot of social supports, even helping people get IDs, really basic tasks that seem not like a big deal, but when you're dealing with mental illness, or maybe you've been on the street for 25 years, some of those tasks that seem simple, like getting your state ID, end up being a really difficult task to complete. And I want to talk a little bit, I guess, about safety out in the street and out in the camps. I like to call it common sense safety. As long as you are paying attention to your surroundings, what's going on? Who is in what location? Are there things around that could be used as a weapon? How are people acting? Do people seem calm? Do people seem agitated? Do people seem intoxicated? If you're aware of what's going on around you, just by observing, most of the time I think that you're going to be really safe. There was only one time when I ever felt unsafe, and surprisingly enough, that was when I was surrounded by many, many other people, not just the person who I felt unsafe with. Intuition. Rely on your intuition. Your senses are picking up on things that you may not be immediately cognitively aware of, and so if you feel that something is unsafe but you can't put your finger on it, there's a good chance that it is, and so simply leave that situation. Respect. If you enter people's areas respectfully, if you are genuine, if you don't seem fearful, people generally will give you that respect back. I found people to be incredibly receptive and respectful to me, and at that point when you develop that reputation, you are, people will actually look out for your safety. As far as environmental safety, if you're going to be out on the street and in the camps, make sure you're dressed for the weather. That sounds common sense, but it makes a big difference in if you're going to be out there for 8 hours a day. Especially in the camps, some of them are more well-organized or cleaner than others. but there's definitely the risk for needle sticks. There may be used needles all over the place. There may be rusted metal, so don't wear sandals. There may be a lot of human waste. Bring hand sanitizer. Hand sanitizer is extremely important, not just for your own protection, but if you're going to be touching other people. A lot of people out there are extremely ill, very physically ill, and you don't know what's going on with them. They may have really compromised immune systems. They may have a lot of chronic illnesses that put them at high risk for hospital admissions. And so be aware that you can also be transmitting illnesses to them. Being out there, it's really important, I think, to understand some of the challenges that everyone are facing. There's so much mental illness out there, and many people have never been diagnosed. A lot of people, definitely you have your psychotic disorders, definitely you have your bipolar disorders and things where people may be manic, but even more frequently, there's so much anxiety, whether it be an anxiety disorder, whether it be PTSD, and whether that PTSD and mental illness helps lead them out there, or if actually being out there and experiencing the trauma simply of being unhoused or experiencing violence on the street can lead to those illnesses as well. In my experience, everything is built on trust, and I had a lot of leeway in my program, and I had a lot of time to really get to know the community that I was working with. And I think that I was lucky in having the time to really engage with folks. Many programs, as I'm sure you guys are aware, have very high caseload demands, and I think that can prevent people from developing the supportive relationships and trusting relationships that are really needed for good collaboration. So when you're out there, if you are in the street or in a camp, in my experience, it's really important to be informal, especially of us who work in mental health care. The idea of boundaries is extremely, extremely important. And in some ways, I think we need to be less rigid with our boundaries. And of course, I'm not talking about having inappropriate relationships. I'm not talking about disclosing a bunch of personal information to the people you're working with, but drop a little bit of the formality. I found that people would call me their friend. They would refer to me as their friend. And initially, having come from mental health, I thought, oh no, I've done something very wrong because they think that I'm their friend, and that's absolutely not the role that I am in. However, I came to realize that when they were referring to me as a friend, they weren't referring to me as a friend in the way that I would think of a friend. People were not calling me after hours. They weren't inviting me to, use alcohol or drugs with them. What they were referring to was having somebody consistent that they trust and that they can count on. So do absolutely be mindful of boundaries, but they will be a little bit different. They will be a little bit less formal when you are out on the street. And I think that they absolutely need to be slightly less formal, yet still held, which is kind of a delicate balance when you're out there. I think kind of a good way to do that is by using motivational interviewing, and not just the actual techniques, but the entire spirit of motivational interviewing, where you are not the person telling somebody what to do, and you're not expecting them to do what you say. It's an actual working relationship where you're helping that person to facilitate change in themselves. And you can do that by accepting who they are, accepting some of the challenges that they are up against, and really approaching every situation with curiosity and openness. Because although we do have all of our statistics, and although we know that people are facing many of the same issues, each community is going to be extremely different. And not just community from city to city, but each camp you'll find has its own social rules and expectations. And so it's really important when you're approaching each individual, every new camp, every new community, to approach with curiosity and to be open to also learning and understanding that community. Patience is extremely important, and small victories are a big deal. A lot of people, especially who have been out there for long periods of time, simply aren't going to be ready to be housed. They're not going to be ready to get established with a primary care doctor. Some of the things that we take for granted are extremely, extremely intimidating to people. And so I think that that's where the engagement and really developing a relationship becomes important. Once that trust is developed, and once they do trust your judgment, and they don't feel pressured and they do feel accepted, people will begin to come around to making small changes, and those small changes are very important. Integrating into your community. Definitely learn your community. Be out there as much as you can. And when I mean learn your community, be aware of all of the different nuances that are going on. There may be conflict between camps. There may be conflict between individuals. Learn your community, and not just, not simply the people who are out there unhoused, but also all of the community resources. Not just your community resources, but, for example, develop relationships with the people who are also out on the street. For example, maybe the guards at the bank around the corner. They see a lot out there. Introduce yourself. This will also help to increase your safety. So number one, they know what you're doing out there. Number two, they're already out there. They're looking around. They're seeing what's going on. If you do ever get into trouble out there, they have their eyes open. And also, sometimes they can tell you where, if you're looking for a particular client that you have, people outside in the community, they know where they are. They know where everybody is. And sometimes these people that you won't think of actually end up being a fantastic resource. Maybe the person that you're trying to establish a relationship with or develop trust with actually already has a relationship with that guard or with the groundskeeper. And that person can end up vouching for you and helping you to develop a relationship a little bit. We talk a lot about safety nets, but from my experience, a lot of our programs are very siloed. Even though we may be serving some of the same people. And so I highly, highly stress and recommend collaborating. We don't need competition between programs. We need to all be on the same page. Part of the problem, I think, in our communities is that we aren't a community. And when that community is created, it helps people to integrate a little bit better. And that's all I have for now. Thank you so much for letting me participate, and I hope some of that was useful.
Thank you, Amanda. That was fabulous and very useful. We have a number of questions that came in while you were speaking, so I'm going to start while your mic is live and toss one of them back to you. One thing that you didn't mention was the role of law enforcement and whether your work was done in a team formation. So is there an outreach team that you were a part of? How's it structured? Was law enforcement part of that? Did you ever have a police escort? Did you encounter illegal activity?
So I did not have a police escort. We do have an outreach team made up of law enforcement in Sacramento, but at the same time, those are often the very, very same people who end up having to take people's survival gear from them. And so there's not necessarily a good relationship with them. And in Sacramento, and it may be the same in other areas, but I can only speak to Sacramento, housing is so extremely difficult to find. We really lack affordable housing. We really lack even shelter. We have very, very few shelter beds for the amount of people who are out there. And some of our officers are fantastic. Some of them are trained in different de-escalation techniques. Some of them are even mental health professionals. But in my experience, people are so terrified that their supplies are going to be taken. People are so, a lot of people have warrants for, sometimes they're for serious offenses, but sometimes it's for camping. Sometimes it's for taking the light rail without a ticket. And so when the police are around, people tend to flee, and they will tend to be less trusting of the provider. But that's not to say there's not a role for law enforcement, as we saw an example where law enforcement in another area is providing a really fantastic service. And so I think a lot of it is up to the training that the law enforcement receives. But I was not accompanied by law enforcement, but I absolutely did have relationships with law enforcement because sometimes they would know where my people are.
Right. All right, so there are a number of questions that came in about outreach and for Amanda, but I want to point out to everybody that in the next series of sessions, Facilitating Access, Session 1C, Amanda is a presenter, so you'll be able to hear more from her at that time. I want to bring a question back to Brian. Is your mic live? You're still with us, I hope. There was a question, Brian, about substance use disorders and whether they contribute to post-traumatic stress disorder and bipolar disorder, or is it actually a byproduct? Does it work the other way, that bipolar disorder and post-traumatic stress disorder kind of generate the condition in which substance use disorders arise? Do you have any knowledge about that?
Yeah, I think it is more the second than the first, particularly when you're looking at post-traumatic stress or otherwise as its basis being around trauma. We're really talking about experiences that the individual has had and use substances as their coping strategy. So what you see a lot of times is individuals, if you use a veteran, for example, who has witnessed, and this is what we see in veterans a lot, is that roughly 80% of them who witness something say that that's the form of trauma that they have, will actually use substances as their coping mechanism or the soothing mechanism. So it tends to be more the second example than the first.
Right. And a question also came in about veterans. So while I have you, I'm going to pose that one. The question's about Vietnam-era veterans. As they age through our system, since I'm a Vietnam-era person, I know about how old they are. Age seems to complicate the conditions that we're talking about. Do you have any knowledge, or have you seen anything about that?
Well, you know, I will say that there's a yes and a no to that one. Age does bring more complications. But I think what really seals it in is not the age, but the amount of time. Because many of these Vietnam-era individuals have been going through the same set of circumstances for 30 and 40 years now. And it's that settle in where they've had no treatment strategies, no alternate pathways provided that solidifies their peril or their turmoil that they're going through at the time. So it's really looking at more so the condition worsening, yes, because nothing's being done, but also for the length of time that they've sustained that same feelings.
Right. Thank you. Melody, there were so many questions that came in for you, and we only have like 3 minutes to even deal with any of them, but just to give it a try. One of the questions was about how do you keep people in the queue for permanent housing? So, you get on a list or you're part of coordinated entry and you're prioritized for housing, but the person wants to and is willing to go into substance use treatment. How do we keep their position so that they don't lose the housing opportunity while they're pursuing treatment? Is there anything you've learned about that level of coordination?
Thanks, Marty, and that's a great question. I think that one of the benefits of having this new Medicaid benefit in our state is that the supportive housing services that we can essentially help individuals navigate multiple systems, and so and we work very closely with our coordinated entry partners, and so absolutely, while that person may be addressing their substance use treatment needs or their mental health inpatient treatment needs, the supportive housing services can continue to provide, to be able to do that outreach to landlords perhaps, or help that individual get on multiple waiting lists for affordable housing. And so because the services that we have connected to the Medicaid benefit works in tandem with the housing, it really is a separate service. And so we are certainly focusing on the permanent supportive housing model, but we're focusing on the services that we provide and following the fidelity to that model of giving people choice and helping them navigate and looking at multiple options for what their housing wants and preferences are.
Right, that makes sense. I'm sorry we're not getting to everybody's questions. We've tracked all your questions, and we'll figure out how we can do follow-up in some amazing way or another. Thank you, presenters. This was absolutely a very dynamic panel, and the questions that are coming in all have to do with how do I do that, and can you tell me more, and are there tools to support the work? How do I apply that in a rural setting? How do I make sure that I'm coordinating across the sectors of my community? Those are the issues we aim to address in the sessions that will follow on this one, the workshop sessions. So I hope you all will join us. Join me in virtually thanking Brian, Melody, and Amanda. You all were really fabulous. I'm putting their contact information on the screen. There's also technical assistance that's available, and thank you to SAMHSA for allowing us to have this session. I hope everybody will join an additional workshop today and be back for the closing roundtable when we'll try to pull some of this together, and if we got answers to your questions in another session, we'll be speaking to those issues then. Thanks, everybody, and have a great summit.